Registrations are now open for the 12th South African AIDS Conference, the SA AIDS 2025 conference, taking place on the 8th to the 11th of September under the theme Unite for Change, Empower Communities and Redefine Priorities for HIV/AIDS. This pivotal gathering will bring together leaders, researchers, implementing partners, academics and advocates from around the world to address the evolving landscape of HIV/AIDS care and prevention. Part of the key highlights of the conference is to engage with experts exploring cutting-edge research, discuss innovative solutions, and to network with global communities dedicating to ending the HIV/AIDS epidemic. For more on this, we're now joined by SANAC CEO, Dr. Thembisile Xulu. Doc, good afternoon. Thank you so much for your time. Really do appreciate it. South Africa's HIV/AIDS conference is held every 2 years, and it's become sort of a mainstay in the global health calendar, but also a barometer of the advances made in confronting HIV and controlling infections in South Africa. Talk us through what the conference has been able to, over the years, achieve as far as research outputs, collaborations, as well as partnerships concerned.
Thank you so much, Oliver, and good afternoon to you and your viewers. So we are quite excited to be hosting the South African AIDS Conference in Gauteng for the first time since the conference began. From the 8th to the 11th of September, we will be at Empress Palace. Aligned with the theme, which you have just mentioned, the key area that we want to focus on is that South Africa is still the country with the highest burden of HIV in the world. So we remain a big player in terms of HIV being a global health priority. And key discussions at the conference are really going to center around how we need to prioritize access, how we need to prioritize equity, but also issues of sustainability by making sure that as we introduce innovations, we continue to keep communities at the center of the response. We've got two conference chairs, Dr. Candice Chetty and Dr. Kate Rees, and we are quite honored as well at the opening session that we are going to be joined by the WHO Director General, Dr. Tedros, as well as the UNAIDS Executive Director, Dr. Umamuwini Bianyima. But in the lead will be the chairperson of SANAC, the Deputy President, Honorable Paul Mashatile, who will be conducting the opening address. And some of the issues of collaboration, for instance, will relate to the newer long-acting injectable for prevention, which is called lenacapavir, and how communities need to be able to partner with pharma, supported by government, so that we've got access to this potentially life-changing HIV prevention initiative.
Let's talk about the preventative work and research that's being done. The uptake of PrEP has been relatively slow, given just the significant effect it could have in limiting the spread of HIV/AIDS. Would a longer-lasting injection replace that, let's call it a mechanistic barrier that a lot of people face when thinking about adopting PrEP?
Absolutely, Oliver, and I mean I'm proud at how you've kept up with developments, because when it comes to pre-exposure prophylaxis, which is something that you take prior to a sexual encounter to make sure that you don't don't acquire HIV, we've got oral PrEP, then we've got the dapivirine ring, which is actually a ring that women insert into the vaginal canal to make sure that it releases antiretroviral therapy over a period of a month. Then we've got now injectable PrEP. In all the studies that we did, in the two options that we had in terms of injectable PrEP for 2 months and 6 months, we saw that injectable PrEP had the highest uptake. So we are seeing that adolescent girls and young women, as well as other key and vulnerable populations, are actually preferring injectable PrEP. The trick will come, as you say, in how we offer it as a service delivery model, because these are people that are not living with HIV. So medicalizing it and offering it in health facilities might be a good start, but we need to be moving towards reaching people in communities where they are, so that it makes sense for somebody that's not living with HIV to access PrEP even outside a health facility, but at community level. Hence my my emphasis at the beginning about making sure that communities are at the center of the response.
What does this look like in practice? Like my annual seasonal flu vaccine?
It's a 6-monthly vaccination right now. It's called lenacapavir. We have been lucky as a country. So one of our funders, the Global Fund, has actually gone into a negotiation with a pharma company called Gilead and the South African government, together with 8 other countries. So there are 9 so-called early adopter countries that have been identified to get access to lenacapavir. So you are essentially screened for HIV, you are screened for sexually transmitted infections, and you then get a loading oral dose for the first 2 days, and then you get an injection, and then 6 months later, you then get a second injection. It's a subcutaneous injection, very small needle, Oliver, very, very small, so nothing too painful, but essentially one that has got an efficacy of up to close to 100%, and one that really works.
Yeah, I'll invite you back to studio when you begin rolling this out, or when it's being rolled out in South Africa. Perhaps taking it live on air will encourage a lot more people to consider it as an alternative. But you spoke there about funders, and I think funding generally will be the elephant in the room of the gathering, with USAID, of course, having pulled its funding from crucial HIV/AIDS projects and research. And a great deal of research has been done over the last 2 decades as far as HIV/AIDS is concerned. I mean, we've got ARV treatments now that leads to undetectability, which of course is important for untransmittability. But with reduced funding for HIV/AIDS research, where does that leave the sector?
It leaves the sector, I think, in a space where the government has actually said this platform, which is the AIDS conference, is a platform for researchers to come together with communities, with other scientists, with implementers, to actually share, to debate, and to decide on strategies that are most efficient, but also to speak about issues of integration and models that actually make sense and are sustainable. We were fortunate when the Department of Health did put forward an application to National Treasury. Some money was released for research, but a key was that there were also some commitments that were made by private funders for research.
I've been in conversation with the CEO of SANAC, Dr. Thembisile Xulu, talking to you there about the SA AIDS conference coming up. We had a break in transmission just before that break, but we have Dr. Xulu back with us. Dr. Xulu, you were responding to the question of R&D financing and funding and why having filled the vacuum, having left by organizations such as USAID, has been picked up by other people, and that there's no cause for concern. Do you perhaps want to complete that thought there?
It is a cause for concern, Oliver, but what the pullout of PEPFAR has required us to do is to think innovatively and to think differently. We need to reimagine the HIV program and think about what does a sustainable HIV program look like. So our research is funded to inform policy, and for policy to design sustainable programs, it needs to look at things like integration of TB, HIV, non-communicable disease programs, etc., because offering programs in silos is part of what drives program costs. And if we are to make sure that the investment that was made by PEPFAR is then used to build resilient and sustainable health systems that are able to offer integrated services, this is the solid framework that will make sure that our systems are resilient and actually can absorb any current or future shocks.
Dr. Xulu, let's talk about the real miracle of HIV/AIDS research advancement of the last decade or so. And that is, of course, that antiretroviral drugs now have put us in a position where we can get people to become untransmittable, people living with HIV, and that untransmittability is really important. It needs to become undetectable for it to be untransmittable. It means that people need to be on ARVs, and consistently so, and of course there are various other supports around that. Of course, nutrition support is a big one around that. Are we getting the delivery of that right in South Africa?
So we are struggling with the second 95. I think you are aware that we are now working towards the 95 targets of UNAIDS. The first 95 is people testing. South Africa is at 96%, so we are testing. The second 95 is the number of people on treatment. We are at 79% as a country, and that is low. And if people are not on treatment and staying on treatment, it means the third 95, which is the viral load, even though we are doing well there, it only reflects the second 95. So the message that we are putting across, as the minister has launched the 1.1 million campaign to make sure that we bring people back onto treatment, is the U equals U message. And U equals U essentially means undetectable, means untransmittable. Once you are on your antiretroviral treatment, you take it according to the instructions that you are given, your viral load becomes undetectable. It is practically impossible for you to pass on HIV to your sexual partner or even to your unborn baby, not just during pregnancy and delivery, but also during breastfeeding. So that is the message that we are putting across to say, you can live with HIV, you can love, you can live long, and you can be able to protect your loved ones. And we are starting to see some of the results in terms of people coming back onto treatment because they understand the fact that when you are undetectable, you cannot transmit.
Why is it that we have 21% of people living with HIV in South Africa not on ARVs? I wouldn't assume it's a ARV availability issue. It must be something else. What is it?
It's a multiplicity of factors. Part of it is people were only able to access 1 or 2 months worth of treatment at a time. You can imagine that when you are a patient and you are well on treatment, coming every month means taking time off work. That is why a month ago, the Director General of Health has now issued the 6-monthly multi-month dispensing method where clients are able to access treatment. We've also started what we call the CCMD, where clients are able to pick up medication at their local mall, at their local pharmacy, and don't have to come to health facility. The change that we've done also to medication that is more user-friendly, where you are taking 1 tablet once a day, has addressed the issue of treatment fatigue that was making patients not want to stay on treatment. So it was a multiplicity of factors, and we've come up with comprehensive strategies to address them.
Dr. Xulu, thank you so much for your time and thank you so much for your work, and all the best for the SA AIDS 2025 conference. Really do appreciate you joining us.